So the next presenter um, is very interesting. As Anthony had said early in his presentation, his parents and himself are from Jamaica. We've got a large Afro-Caribbean population in the Toronto area and in Canada as well. So prostate cancer, from what we've seen globally, affects Afro-Caribbean men in the Afro-Caribbean islands. As we look at the top 10 countries with the highest death rate, places like Jamaica and Barbados and Trinidad and Tobago figure very highly in those numbers. So we were interested to know what was happening in the Caribbean. Everything we do here are focused on Canada, the Toronto, the US. So what is happening within the Caribbean in terms of prostate cancer? So we were honored to have the next speaker, who I'm going to introduce. It's Dr. Belinda Morrison. She's currently a senior lecturer in the Department of Surgery and a consultant urologist at the University of the West Indies and the University Hospital of the West Indies. She's also the program director of the residency training program in urology at the University of the West Indies. Her experience is in teaching, research, and clinical care. Her 16 years of experience as a clinician has given her a vast experience in the management of urological malignancies at various stages, including prostate cancer. Her clinical practice encompasses outpatient consultations, emergency management, and surgical procedures. The large volume of patients in her practice allows her to incorporate practice guidelines in management as well as observe the outcomes of their treatment. Though her practice is primarily in general urology, there is a specific focus on prostate cancer and andrology. This experience has allowed her to report on various aspects of prostate cancer in Jamaica. Her research has focused on prostate cancer, screening, risk factors and associations, surgical outcomes, and pathological findings. This has allowed for the comparison of other non-Black prostate cancer populations, as well as to provide a framework for collaborative studies in other areas. She's also a collaborator and member of the African Caribbean Cancer Consortium. So this next presentation is going to be online because Belinda is in Kingston, Jamaica. So we're going to watch it on the screen here, and I'd like to pass it over to Belinda.
Good morning, good morning.
Here.
Is everyone hearing me? Good morning. Is everyone hearing me? Good morning. Is everyone hearing me?
Just have to bear with us. This is brand new for us, going hybrid and thirdly, but
okay,
she's there.
Is everyone hearing me? Just checking if everyone is hearing me.
Give us a sec, Belinda, while we bring you on to the screen.
Okay, no problem. Okay. Is everyone hearing me? Hello? Is everyone hearing me?
We're hearing you.
All right, perfect. So thank you so much. It's a pleasure to present. I was just very happy when I was asked to present at this forum. As was introduced, I am a practicing urologist in Kingston, Jamaica, with a teaching hospital there at the University of the West Indies. And I also supervise the residents. And our hospital sees a large bulk of patients across the island. We are the hospital that's affiliated with the university. So we have students not just from Jamaica, but from many other Caribbean islands. And it's always a pleasure to share. I actually teach and work and live in Kingston, Jamaica, but I'm just gonna show you a little piece of where I am right now, just for you guys. I wanna make sure that you can see my background. Can you all see my background? Does everyone see the background? So that's a background of the pristine beach where I'm at in Trelawney, Jamaica. And I think it sets the stage for my discussion where we're gonna talk a little bit about the Caribbean and prostate cancer. It's more than just the disease, it's our background, it's our heritage. And I wanna focus a lot on that today and just build on what our prior two speakers spoke about, which I know a lot what was spoken about before refers to the experience in North America, but not very dissimilar from what we experience here in Jamaica. So I'm gonna share my screen now. All right, and I hope that this projects well. Okay, so my objectives for this morning really are to, one, go through a case presentation, speak a little bit about the geography of the region, speak a little bit about the epidemiology of prostate cancer in Jamaica, the postulated reasons for the differences, and to summarize. And as we said before, I'm a member of the African Caribbean Cancer Consortium, also called AC3, and the Prostate Cancer Transatlantic Consortium called CAP-PTC. All right, is everyone hearing me clearly? I just want to make sure. Is everyone hearing clearly? Okay, great. So I'm gonna start off with a case. And guys, this is a far too familiar case that we see in Jamaica. This is a 61-year-old patient of mine. He's been a patient of mine since June of last year. He was a recently retired police officer in apparent good health. He was married, he had grown children, he had just retired, and now he was looking to that next phase of his life. He went to see his family physician because he started to have some chest pain. So in the past, in the line of duty, he had received a gunshot wound, and he was told that the bullet did not come out of the chest. So every now and again, he would have pain in the site. And he said, you know, he started to have pain in that general area, mild to moderate pain, requiring the use of medication. So he sought to just go and see his physician to have it checked out. He did admit that he infrequently sees a doctor because, of course, he's well. He has no known illnesses, and he really doesn't do routine checks. It's not a requirement for the police force to have annual physical, so he didn't need to do one. When he was seen by his family physician, he decided to have a CT chest done. And it showed multiple bilateral lung nodules up to 1.7 centimeters in size. So these were significant nodules. His family physician also at the same time sent him to do his male executive profile, and his PSA was 361. So what happened next? Well, I saw him. He was referred to me, and the thinking was that this possibly could be prostate cancer, but because prostate cancer so rarely spread to the lung in this way, it was thought that he had another primary as well. He came to see me, obviously well-looking man. He was obviously worried because he was an intelligent man and knew what the implications of this were, but he was confident that everything would be okay. And what was interesting and important was that he was supported by his wife at consultation. I mentioned this specifically because so many men present to you for either screening or treatment and they are alone. And it's not as though they're single or they don't have a partner, but they really come without support because they're trying to be brave in the face of it all, and they're afraid to tell their spouses. And there's a stigma of what seeing a urologist and having a rectal exam will mean, and also what the stigma of what the treatment and its side effects will bring. So I reassured him, offered some empathy, and I planned to do a biopsy on his prostate. I will say when I examined his prostate, it did feel malignant, but overall he looked well, and all the other parameters in his executive profile were normal. So I did do a biopsy, and almost all the cores came back positive for significant prostate cancer. We did a bone scan as customary with a PSA of that level to see if there's any spread, and surprisingly, there was no bony spread. I did an MRI of his abdomen and his pelvis, and it showed that there was an enlarged pelvic lymph node. So at that time, I made a diagnosis of a metastatic prostate cancer. I still considered whether or not he could have a metastasis from some other area to the lung or even a lung primary. But I thought that this may be very aggressive prostate cancer that had no spread to the lungs. And rather than going and doing a biopsy of the lung, I discussed with the thoracic surgeons who thought, yes, a biopsy of the lung could be done, but if we thought that this was prostate cancer, we could treat him for a period of time for his metastatic prostate cancer and do interval imaging with a CT scan to see if the lung nodules had gotten smaller. And if they did, it would suggest that this was metastatic disease. So that's what we did. Rather than offering him a biopsy of the lung, we started him on hormonal therapy, which is the mainstay of treatment for metastatic prostate cancer, and also the most common treatment that is offered to our patients, at least in Jamaica, because most of our patients, I would say about 70%, are diagnosed with metastatic prostate cancer at onset. So we started a drug called leuprolide and also abiraterone acetate and prednisone. And he responded very well, very, very quickly. Within months, his PSA was undetectable, and at a year, it remained undetectable. We decided a year later to do a repeat CT scan, which showed a reduction in not only the numbers, but the sizes of the lung nodules, which were now on average 0.3 to 0.4 centimeters. And this we recognize now suggested that what he had indeed was metastatic prostate cancer to the lung. So it showed me just how not only metastatic it was, but how aggressive it was, that it would spread to lung, where we know normally it would go to bone or lymph nodes. He was doing quite well. He never complained until, I guess, visit after visit, he saw that his PSA was undetectable. He opened up to me that, listen, he needed to please his wife. And she was right there sitting beside him. He said his erectile dysfunction was bothersome. Since starting the medication, he had absolutely no erections. His desire for sex was less, but it was still there. But he wanted to know if he could come off of his medication. And, you know, his wife at the time said, you know, she really prefers to have him alive than to, you know, to be satisfied. But we discussed the options, and he opted to go on a period of intermittent hormonal therapy. And we started that. And he's been on that now for the past 3 to 4 months. His PSA is no longer 0. It's now like 0.4. But his erections are back. And I saw him maybe a week ago. He said his erections are back. He's happier. His wife is happier. But I cautioned him that we may need to restart the hormones if his PSA started to inch up a bit. He saw another physician for another reason, and the physician just decided to request a CT chest. And what it showed was that the nodules had started to increase in size. So this was causing him some concern. And I told him it probably was a sign that we would have to restart the hormonal therapy. And his journey continues. And I'd like to use that as an example because this is the typical patient that we see in Jamaica. And even though Jamaica doesn't represent the Caribbean, I'll put to you forward in the data that we have that this is quite a common case in our Caribbean region where men come in not because of screening, but because of case finding. And usually at that time, they are metastatic at diagnosis. So you saw the waters behind me, the beautiful beaches, the beautiful beach behind me. And this is what is typically seen in our Caribbean region. It's that region in the world we're comprised of islands as far down south as Trinidad and as high up as Cuba. So there are many similarities, but also differences in this region. There are lots of islands with beautiful beaches. It's a site for tourism. That's one of our major income earners, as you all know, and rich history and culture. However, there are differences because historically our backgrounds are different in terms of the genesis of our people. We know that most of our people were migrants from different places. So some from European countries, we have some from Africa, some from India, some from China. So there's a great melting pot in our community in the Caribbean. Because of the difference in historical backgrounds with the islands, there are therefore differences in cultures, traditions, and even cuisine, which influences the way that we behave and the way we are right now, even to this day. Our languages are different. Sometimes in Jamaica, we feel as though it's only persons who speak English are in the Caribbean, but that's not true. There's Spanish-speaking countries here, Dutch, French, even Portuguese. So there's a mixture of different languages and cultures and ethnicity, and also resources. Several of our island states are independent, but there are others that are still colonies of countries like the United States, the United Kingdom, and even France. And so it impacts on our economics and what we're able to offer to people in our countries. And therefore, our surveillance systems for medical reasons may also be different and perhaps has some bearing on why we see differences in something like prostate cancer across the islands. Despite the fact that we're from different historical backgrounds, the majority of the persons in the Caribbean are of African descent, primarily Central and West Africa. So we know that from West Africa, slaves were brought in for maybe a period of 400 years or so to the Americas. Several went to South America, many went to the Caribbean and North America. And so many of us are descendants of Central and West Africa. However, there are also persons who came as indentured laborers from India, settled in places like Trinidad. And even though Guyana is not considered a part of the Caribbean, so to speak, we factor them in on many of our discussions, and they're part of the West Indies. There are also persons who migrated from Spanish-speaking countries and settled in various islands. And so we're this big melting pot. So what does that have to do with prostate cancer? So prostate cancer, we know globally, is the second leading cause of cancer diagnosis and the sixth most common cause of cancer death. In the Caribbean, the incidence rates vary, but for the most part, for most islands, prostate cancer is number one. I can speak for Jamaica. For maybe the last 50 years, prostate cancer has been our leading cancer. Barbados, Trinidad, for several countries, prostate cancer is the number one cancer diagnosed overall in men and also overall. But we also have one of the highest mortality rates of cancer in the world. I wanted to look at this chart where I was displaying both the incidence and the mortality of prostate cancer across different regions. So we have Guadeloupe and Martinique that are small islands, maybe populations about 200, 300,000. They are reported to have some of the highest incidence rates of prostate cancer in the Caribbean. But if you notice, they have very low mortality rates. These countries are actually colony countries of France, and they are well-resourced. They do have well-documented proper surveillance systems and also registries, so they can accurately report data on their number of cases. Barbados, also a small island, 300,000 persons, has a very accurate database system there. It's much easier to manage when it's a smaller country, but also better resource country. And so you see higher levels there. Several of the other islands do not have as well, some do not have registries. So when we get this data, it may be based on hospital-based studies, or IARC, which is the International Agency of Research on Cancer, extrapolates the data from these hospital-based studies to give us these incidence rates. So I do believe that some of these rates are actually underreported, even in Jamaica. We know years ago, Glover from Hopkins came to Jamaica to do a study, and he recognized, this was almost about 20 years ago, he reported an incidence rate of 304 per 100,000, much higher than that for Guadeloupe, which is a little bit over 180 per 100,000, and certainly for Barbados, that's between maybe about 110 per 100,000. So we know that they're underestimates because of the absence of registries or the quality of registries. But even from hospital-based studies, we're able to say the prevalence of the disease is high relative to other cancers, but maybe the numbers are a little off. What you do see, as however, is that even the countries that have the highest incidence rates, Guadeloupe and Martinique, they appear to have the lowest mortality rate. And the question is it that their cancer is not as aggressive, or is it that they have better resources to treat, to screen, first of all, diagnose and treat? And that's a matter of discussion. So we have the highest mortality rate of prostate cancer worldwide, ranging from between 15.1 to 74.1 per 100,000 population. This, my friends, doubles that which is seen in the US or the United Kingdom or greater. And among 21 English and Dutch-speaking Caribbean states, prostate cancer is the commonest cancer-related deaths in these countries. So it's not unique to just one island. Overall, it is so. So this is a big melting pot that is affected by this disease in terms of prevalence and mortality. Naturally, it will affect us because the more prevalent this disease is, greater finances are needed to screen, to diagnose, and treat. And so it impacts on the budget of any country involved. And it's obviously always more expensive to treat metastatic or advanced disease than it is to treat early stage disease. It affects persons emotionally because it's a disease of the person, of the relationship with man and wife, of the family. So emotionally, it's not just limited to the patient himself, but the entire family and the community. The workforce is affected because this disease in our population are affecting younger and middle-aged men. So of course it affects their productivity. And even in my index case, Mr. F, who had just retired, many policemen, even at 61 having retired, take on various other roles and tasks. So certainly this impacts on even finances within the family. And ultimately, it perhaps can cause loss of lives. So what accounts for the differences in our incidence rates and mortality in the Caribbean than in Canada, in the United States, and in the United Kingdom? And I'm going to suggest that it's a complexity of various factors, things such as genetics, cultural or behavioral factors accounting for late diagnosis, inadequate screening, and differences in resources. So let's go into each bit by bit. We know that men of African descent, and I say that tongue-in-cheek because the new thought and the new jargon is not necessarily to say people are of African descent, Because in the Caribbean, just because of what I just discussed, this great melting pot that we are, we may look at ourselves, I look at myself and I consider myself to be a Black woman, but in times gone, we would say, okay, I'm an African or Afro-Caribbean woman. And the new science is suggesting less and less to depend on that terminology and more so to look at the phenotype, because many studies have shown that persons who refer to themselves as Afro-Caribbean or Afro-American, when genetic studies are done, they are not much different from the genetic studies of someone who refers to themselves as Caucasian. And this is simply because of the rich cultural heritage, well, not cultural, but the rich heritage we have in terms of our descendants. And so, but that being said, persons who identify as being Black generally have a more aggressive form of prostate cancer, and they appear to present at a younger age. Now, we know about these big genome-wide association studies or GWAS studies, and they found many, many, many genes that are associated with increasing the risk of prostate cancer. Too many to name. And of those genes, maybe at least 30% or so of prostate cancer can be explained. But how does that translate to us in the Caribbean? There are studies, genome-wide association studies, that have been looked at in persons, Black persons, say in the United States, in the United Kingdom, that may increase their risk for prostate cancer. But many of these studies have even Blacks underrepresented, and certainly men of Caribbean descent underrepresented. So we can't truly say what are the major players in the game for us in our population. We're underrepresented, yet the same guidelines or rules are to be applied to us for diagnosis and treatment. So that's something that needs to be addressed. There are very few studies in the Caribbean that have looked at GWAS in our men. And one of the reasons is just resources. Our universities do our best at research, but with lack of resources on our own, we may not be able to do as many of genetic analysis or analytic studies as we would want. What has helped is being parts of consortia like the AC3 and the CAPTP, where we have, cross collaboration, sharing of tissue and data, and what augurs for more research and better, information and resources to our island states. So several have been done. I mean, the HOXB13 gene has been detected in Martinique, also a French territory, and Guadeloupe has also done their fair share of work on trying to identify genetic risk factors for prostate cancer. 1 or 2 studies from Jamaica looking at inflammation and genes, and very few studies indeed. So I think that is an area that is needed to be invested in terms of looking at research that more represents us. A really nice study was published some years ago in 2008 by Ben Shlomo. And I suspect, working in the United Kingdom, he saw that there was a difference in incidence rate of prostate cancer across the various racial groups that are there. So he looked at the different racial groups, Black Caribbean men, Black African men versus European men in the UK. And what he found was that the Black men, both the Caribbean and the African men, had a greater risk of developing prostate cancer with higher incidence rates than white men. Their rates were slightly lower than that which was reported by the United States at the time. And he thought that migration may be associated with this increased risk, as well as a gene-environment interaction. So Volaki Adedina is the PI of the CAPTC consortium, of which I'm a member. And she took this whole theory to even greater depth, where she conducted a review looking at the disparities in Black men who identify themselves of being African descent. And she looked at the literature that was out there looking at Black men from the United States, the Caribbean, the United Kingdom, and West Africa. And what did she find? So these are just summary tables from the data. What she saw was that when we looked at the incidence rate of prostate cancer for men who were identifying as African, now this was a paper from 2006, and perhaps if she were to write it again, she would say Black Caribbean versus African Caribbean. But African Caribbean men at the time had a much, much higher incidence rate of prostate cancer than did Europeans, and South Asian men were lowest. And the risk ratio was starkly different, and it was very high. The risk ratio of having prostate cancer in African Caribbean men was 3.07 versus European men. So we see here, this is consistent across the data that men who identify as Black have much higher risk and higher rates of prostate cancer. The Black Caribbean men, importantly, in our table or chart to the right, you see that the Black Caribbean men had a higher rate than the Black African men. So our rates were even higher, despite what is our perceived shared genetic ancestry. So she theorized that this all had to do with the slave trade, which was an ugly, awful event that occurred many, many years ago. But she believes that with the slave trade, where many slaves, many Africans from West Africa, from Benin, Nigeria, Ghana, Senegal, Gambia, Mozambique, and Angola, were transported to the Caribbean, the Americas, coming to islands like Barbados, Cuba, Haiti, Dom Rep, Trinidad and Tobago, Brazil, and Jamaica. There was this sharing of this genetic material, if you will, and the fact that persons from both countries, or persons who have this share from both countries, I should say, have high rates of prostate cancer, it is thought that it's due to some genetic reason. So if we look in the US, if we look in Europe, persons who are from African backgrounds and Caribbean backgrounds have high rates of prostate cancer. And it is thought that it's because of their shared ancestral ethnicity and genetics. But one may look and say, but if you look really on the data right now of prostate cancer incidence rate in many of these West African countries, what is reported, their rates appear low. And maybe when I was a resident, people used to say, well, prostate cancer doesn't occur commonly in Nigeria and those countries because the reported rates were low. This, unfortunately, was because of underreporting. Many of these West African countries do not have well-established registries that document all their cases. So a few of the case reports that came about were from hospital-based studies, which are highly biased. And in addition to that, these countries were still battling other medical or health-related concerns that perhaps in Western countries we didn't have to deal with, like infections or so on. So screening was not properly, screening was not a national policy, screening was not advocated. So this could explain why, if you look at the rates of prostate cancer in these countries, it appeared low, but newer data is emerging, especially with collaboration with a lot of these consortia, and we're seeing that the rates are as high as we see in Caribbean countries, or almost on par. So it's believed that this higher rate is related to our shared genetic background. And I think there are obviously more studies ongoing and more studies needed to explore this even further. But I always say the genetic factors we can't really control for. It's nice to know them because it perhaps can lead to proper counseling of men and maybe even therapeutics in, manipulating therapeutics in the future. But right now, the things that we can perhaps control are our lifestyle behavior and our culture. So it is definitely a culture in the Caribbean for men not to present to see a doctor. And I'm not sure if it is seen in many other environments or any other countries, but in the Caribbean, our men don't see the doctor frequently. If you go to a public health clinic, it's more likely that you'll see a woman sitting there than a man. Men don't generally go to the doctor until they feel very ill. Of course, they're also afraid of being told they have an illness because of stigma, because of what it will do to their status in their families, their relationships, and their communities. And many of them are in denial. I can't tell you how many times I have men who come in who have a PSA that's high, almost obvious at that time that they have prostate cancer. And they'll tell you they feel well, they don't have an illness, and they do not come back. Or they do go as far as doing a biopsy, and the biopsy is positive, and they don't come back. They say, doc, nothing is wrong with me. And then when they do come back, it's usually when they are now symptomatic of metastatic disease. So it's based on a generalized fear of a diagnosis, fear of what it will mean to them. I also think there are lifestyle and dietary factors that we have to consider. So many years ago, in about 2006, I spent a year in the Greater Toronto area training between Sunnybrook Hospital, University of Toronto, St. Mike's, and Sick Kids. And I remember, you know, the adjustment I had to make coming from Jamaica and the West Indies to the culture in Toronto. And even though, you know, I have a sister who lives in Toronto and many family members there, it's a different lifestyle. I'll give you a basic example. You're at work at a hospital in Jamaica. It's lunchtime. What do you get for your meal? You get a box, almost 3/4 of the box has rice and peas. And then there's chicken, probably 2 pieces of fried chicken or baked chicken, and very little vegetables. That's the routine and that's the norm. So you can imagine when I'm in Toronto and I go for lunch and I'm, you know, you get a cup of Tim Hortons coffee and and a cupcake or a Danish, a donut. It's not our culture. That's not how we eat. And what we eat on a general basis is a lot of carbohydrate, a lot of meat, a lot of fried food, and we don't put a lot of emphasis on vegetables, even though we do have a lot of fruits and vegetables, unique fruits and vegetables in the Caribbean. And I use the Jamaica Health and Lifestyle Survey for data because it's a well-conducted epidemiological survey that comes out of the University of the West Indies and the Ministry of Health. And they've had 3 iterations to date. And the last one that was published was a survey between 2016 and 2017, where they surveyed the population on various indicators of health and lifestyle. And when they looked at persons who consumed fruits and vegetables twice per day, it was only 12 to 17%. And that's disappointing because in Jamaica, there's so many fruits that you can get so easily. You know, in the backyard, people can get a mango, an apple, you know, a lot of them not very expensive. So you wonder why persons don't prioritize eating fruits and vegetables. But our lifestyle has changed over the years as well, even in the rural areas. But persons who consume sugar-sweetened beverages, 32%. Activity is very low. We become very modernized in Jamaica. So low physical activity was seen in up to 48% of those surveyed. And from the prior survey in 2007, 79% of men had never had a DRE and probably said they would never have it. And that, of course, we know is a deterrent to even coming in and having our prostates examined. So the other impact I think that we would have to speak about on our disparities would be screening. Up until recently, we lacked a national policy in Jamaica on screening for prostate cancer. And by that, I mean the Ministry of Health did not say, okay, for all our medical officers of health who work with the government system, you must ensure that once a male over the age of 40 presents to your health center, they should have screening. And they should have screening done every year. And there should be a mechanism to remind this man. That didn't happen. It was done ad hoc by family physicians if they thought it necessary. It was done opportunistically if someone's job required that they do screen, well, not even necessarily screening, but an executive profile or male executive every year. And then the group that did most of it was the Jamaica Cancer Society, which is a nonprofit organization really targeting advocacy, but had gotten involved in screening because they recognize the challenges that we face. Thankfully, this has changed in Jamaica, where we now have a policy on screening through the ministry, and there's a lot of health promotion from the ministry. But in many other Caribbean islands, there is no such policy. So if persons aren't invited to screen, then you're not going to find the cases early. And when you do find them, they're going to be advanced. So if I look at some data that we have on, you know, differences in incidence and mortality rates across several Caribbean islands and a few African states, as well as things like screening. If you look to the bottom of this table, well, the mid part of this table, you'll see public prostate cancer screening or community-based screening is not present in Barbados, not in Jamaica, not in Kenya, Guyana, not in Guadeloupe, only in places like Trinidad and Bahamas. What we would see is that there's localized public screening and individualized screening. So definitely a national policy is needed for things of this nature to promote screening. I hear more about breast cancer screening in Jamaica than I hear about prostate cancer screening. And I'm sure it's so in many islands, and that has to change. So a big factor, I think, however, are differences in urology, in resources. So I listened to my previous two speakers and heard them speak about active surveillance and genetic studies and investment in research. And that's where there is a gap. The Caribbean is a big region, yes, but also difference in resources. Bahamas has probably one of the highest GDPs in the Caribbean to date. Probably gonna change soon. Guyana has found oil and their resources have increased significantly over the last couple of years. But, you know, Trinidad and Tobago, Bahamas, St. Kitts are up there in terms of GDP, and Jamaica is somewhere down the bottom of this chart. What does that mean in terms of prostate cancer and disparities? Well, resources means how you are going to manage your patients. Can you start talking about screening if PSA testing is not available? Now, luckily, we've had PSA testing since its onset, since its discovery years ago, and it is available in both public and private facilities. What we may not have are widespread genomic testing. Genomic testing is only available, to the best of my knowledge, in 2 medical oncologist offices in Jamaica, and that's privately. The cost is prohibitive to the general population, so it's not routinely done. I remember once having a patient who had 2 brothers who had prostate cancer, less than 55 years of age. He was diagnosed. Obviously, this is somebody who needs to have genetic testing done, but the cost was too much for him, and he didn't think it would have impacted on his overall care, so it was bypassed. Do we have all the centers that can afford us the screening? If someone does a biopsy and it's negative, but their PSA continues to rise, do we have other new and novel biomarkers to do, like the 4K score and PHI and PCA3? For my patients, no, not in Jamaica. And for many Caribbean islands, they're not there, at least in the English-speaking Caribbean. So for my patients, if it is needed, I may have to send them to a colleague of mine in Miami, if they can afford it, to get it done. Diagnostics are challenging some of our islands. Most of our islands have widespread ultrasound machines in doctor's office and clinics. CT, MRI, maybe up, maybe down in some of the public centers. We do have a multiparametric MRI for diagnostics available and CT in both public and private facilities, but they're not appropriate to the size of the population. So you may have 1 or 2 machines down and it impacts our diagnostics. Right now, even in Jamaica, I can tell you that 2 of our big centers who provide multiparametric MRIs, their machines are down. So patients are scrambling to get MRIs and their dates may be pushed back for months. PET scans. We have 1 center that offers PSMA PET scanning in Jamaica, and it costs about $2,000. So patients decide whether or not it's relevant to even have a PET scan. And several of our patients who are diagnosed are not properly staged because of the lack of resources. Bone scans are available, but the reagent to do the bone scans can be short a lot of times because we're a small region and we don't generate a large income for our suppliers. So right now in Jamaica, none of our 2 bone scan machines are up and running because of reagents. We do have specialists because we have a training facility, not just in Jamaica, but there's training through the university in Trinidad, in Barbados, and the small islands. And several of our persons not only train in Jamaica or in the region, but they train in North America and they return. So there are urologists, there are oncologists, medical and surgical, there are palliative care physicians, radiologists, interventional radiologists, but not appropriate to the size of our population. And that occurs in many of our island states. And treatment, because we have specialist training, our doctors know how to do a radical prostatectomy, a nerve-sparing procedure. Do we have a robot in the English-speaking Caribbean? No. DomRep does have a robot. And some of our patients who want robotic surgery, if that's their choice, they can fly there, but there's a language barrier, or they can go to North America at greater cost to them. So sufficing to say that's not commonly done. Radiation is available, external beam, and we have IMRT. There's brachytherapy in Jamaica, only available in 1 private setting, and that's cost prohibitive. And then we have the basic forms of androgen deprivation therapy, which are not curative but can control disease. The challenge with it is the newer agents, the androgen pathway-directed therapy. Very, very expensive. Several of them are available in Jamaica now, but at a cost of $5,000 per month to a patient, it's just not being purchased. For our patient, abiraterone acetate that he has is covered under a government health insurance plan called the National Health Fund. And so to him, there is zero cost. And that has changed the game in a lot of our patients, because someone like the patient I presented would not normally have responded so well and for such a long time. But newer generic companies have come about, reduce the cost of drugs so our patients can have longer lives, better quality of life. Chemotherapy is available, but our men do not want chemotherapy. They are afraid of chemotherapy. They've heard horror stories, and generally when the conversation is brought up, it's not something that they're interested in. There are few who go, but not the majority. And so we have a lot of resource challenges that I think has impact on the outcome of our patients. I mentioned before that registries may not be present in all islands, and they may not be properly funded, so we have good, accurate resources for reporting. So in summary, prostate cancer has high incidence and mortality in our Caribbean males, and the etiology of this disparity is a complex interaction between genetics, the environment, and social factors. The outcomes may be improved with early detection by having proper screening programs, improved resources, population education, and research, including greater proportion of men of Afro or Black Caribbean ethnicity. And thank you.
So thank you very much, Dr. Morrison. That was really an excellent presentation. Very informative. So I'm going to open it up to questions from anyone here has a question.
Your presentation was really ton up from the Jamaican perspective. There's a lot that I gleaned from your presentation.
Thank you. Hold on a sec. Let me, 1 sec.
Thank you very much. Very informative. But in my mind, I was just thinking, how many person more like you? I would love to see at least 1,000 more people just like you in Jamaica to do this kind of research and the effort you put into it, and we'll be so much better.
Did you get that?
Yes, I did. Thank you. Thank you so much, guys. You know, as I said, we have a training program, and we do train residents now in the Caribbean. And we have, you know, encouraged them to get involved in academic research. My practice is not just isolated to teaching in Jamaica. I have colleagues in Trinidad, I have colleagues in Guyana and the Bahamas. And as I said, as a part of the consortia, I have colleagues in other Caribbean islands. In fact, there's one project that I'm working on right now where we're looking at the differences in the mortality incidence and the outcomes of prostate cancer across various Caribbean and African islands. And I showed you a few of those slides. It's unpublished data, but we're trying to improve on our interest, our work, and ultimately the outcome of our patients. That's the bottom line. It's not heartening to see men like the patient I presented with advanced cancer. And I'm not saying that you're not going to have some men with aggressive cancer, but we ought to be able to do better for our men. And so, yeah, it's something that we really want to push. And there are other persons in my department, you know, are trying to do the same thing, essentially.
Could you hear me? Belinda, can you hear me?
Hi, Dr. Fleshno.
How are you? I have two. First of all, congratulations. You gave a great talk, and B, I've been following you and your career. So congratulations for all you do. So
It makes us proud. Two
Thank you so much, Dr.
questions.
Fletcher.
Two questions, one serious, one joking one.
Yes.
The serious one is, I'm curious, as a female urologist in Jamaica, what your personal experience is like, and is that something that you think is an advantage or a disadvantage?
Yeah. So first of all, guys, so if you didn't know, Dr. Fletcher was my attending while I was in Toronto. So this is really sweet. I have not seen you, sir, in I think 18 years, I believe. So it's really an honor to see you there and be on the same platform. So the answer to the question is, it's a good thing. I remember when I got back to Jamaica, at the time, there were just two of us in the residency program studying urology. And we always were told that urology was a gentleman's specialty. And I even toyed with the idea of doing female urology after a while, because I figured, that should be more down my line. And my program director at the time looked at me and said, "Are you crazy? All these men in the department are waiting on you to graduate to come and check their prostates." And so the truth is, the truth is, these men, including my own male colleagues, are hung up on having a digital rectal exam done. And I know I used abbreviation DRE before. It means a rectal exam. They're afraid of it. It sometimes prevents them from coming to do the test. Sometimes their wives have to drag them. So I think being a female helps with that because they feel more comfortable. And I have patients who only see female doctors. So you'll have this female family physician. She always sends me them, and you'll find out that they'll tell you, "Doc, I'm only seeing a female." And they come and they say, "Show me your finger," and I'll show them my finger. So I think it helps. This is what I think. I think patients should be able to have options, just like a gynecologist. Some women want to see a female, some women want to see a man. So if there's a gender issue that is going to create a divide, it's best to have, different options for persons to choose. So it has helped, definitely.
Great, thank you. So there are a couple of questions online, so I'm going to read them out to you.
Yes.
So you may have answered this one. What really causes prostate cancer? Is it a genetic factor? Does metastatic prostate cancer cause lung cancer?
Right. So I saw that question from Mr. Edwards, and I just answered one, which was that prostate cancer can spread anywhere, really. But to the lung, it's not very common, but it can occur. And we have seen a few cases where it has gone to unusual places. We've seen the orbit, the brain, so it can go there. It is a genetic disease. It's a disease that affects the genes, that several genes, as I mentioned, and there are different promoters of this, and there are different risk factors association. But I don't think, like some other cancers, you can point to one gene and say that is a distinct cause. There are different things.
Yep. So the next one is, do you see AI being used in research?
So AI, I imagine so. I mean, that certainly hasn't filtered down to us yet. We're still battling getting a PET scan, but I believe it. But I believe that's something that is here to come, whether we like it or not. And even in small resource places, it will get there.
Did you want to? Dr. Fletcher will talk about AI in his presentation. I think that's about it. It's a very powerful presentation, and we really want to thank you very much for presenting today. It was very informative, and we'll definitely have you back at the Walnut Foundation, and perhaps looking forward to work with you on some future research project. I know there are there's a lot of research going on, and we'd love to have you partner with us and UHN.
Thank you so much. It was my pleasure. It was my pleasure. Thank you.
Thank you.